really there's a push for all of us, students, nurses, faculty, to use the same type of terminology. And that's what I'd like to go over with you over the next few minutes here. When you look at a fetal heart rate tracing, there's really going to be two components. The top line is generally going to be your fetal heart rate tracing, or FHTs, or fetal heart tones. And it's going to be essentially a squiggly line, and this is going to represent the heart rate, and it's actually measuring the interval between the R waves on a fetal EKG. The bottom line is just a graphical representation of the maternal contraction patterns, and that's usually represented by the tocodynamometer, or the TOCO. There's a few essential components that you really need to include when you're talking about the fetal heart rate tracing. The first one is going to be the baseline. Your baseline is just that. What is the average fetal heart rate on the tracing? And what you need to have is approximately 2 minutes of this baseline. So it needs to be describable for about a 2-minute period in any 10-minute window. So for instance, in our case, the fetal heart tone baseline would be approximately 125 beats per minute. If you don't have this 2-minute window here, you're really going to have to call the baseline indeterminate. So the first essential component is going to be, what is your baseline? Second is variability. And variability is just how much squiggle is there to that fetal heart rate line. And essentially you're measuring sort of the peaks and troughs of the variability, or of the fluctuations in the baseline. So a flat line is going to equal no variability, and we call that absent. And that's a concerning finding. You might get a little squiggle where those changes in baseline happen anywhere between 1 and 5 beats per minute. We call this minimal. Where we like to be is where we see a pretty good squiggle to that line, where that'll be anywhere between 6 and 25 beats per minute. And that's moderate. And this is where we really like to be as far as overall description. We'd like to see moderate variability. And sometimes we have very wide fluctuations. And that's going to be greater than 26 beats. And this is going to be marked. So we have absent, which is 0, 1 to 5 beats per minute in that squiggle is minimal variability. 6 to 25 again is where we want to be, that's moderate. And anything greater than that is marked variability. We also want to look at accelerations. And again, accelerations are abrupt increases in the baseline. So things that go up. And these can be gestational age dependent. So when we're greater than 32 weeks, we're looking at 15 beats above the baseline and something that lasts for 15 seconds. So there's our 15 above, and here's our duration of 15 seconds. If we're less than 32 weeks gestation, we'll take 10 beats for 10 seconds. But again, accelerations are increases. It's generally a favorable positive response, and that's something that we find very reassuring. Next are decelerations. And the timing of these is somewhat important based on where they happen with the contractions. Put some contractions down here. First type is going to be early. Second type is going to be late. And the third type is going to be a variable. So an early is gradual decrease, gradual increase, tends to be symmetric, and it's lined up with the contractions, where the peak of the deceleration is at the peak of the contraction, and by the time the contraction is ending, we're back up at our baseline. This is related to compression of the head. And basically that contraction squeezing the head, causing a vagal response, which is causing the change in the heart rate, and then it reverses. Late deceleration, again, gradual decrease, gradual increase. Again, looks to be symmetric. However, as we start our contraction here, our baseline is about the same. We start to get a decrease in our baseline heart rate. However, the peak of the contraction does not necessarily line up with the nadir of our deceleration. And once our contraction is over, we're still not back at our baseline. And this really has to do with perfusion. And what we're seeing with this is a decrease in perfusion with a contraction. It's causing fetal hypoxemia, decreased PO2. That's causing the fetus to shunt blood to the brain. It's causing a vasoconstriction in the periphery. Blood pressure goes up. The vagal response to that is to decrease the heart rate to decrease the blood pressure. And again, in order to reverse that process, that's going to take time, which is why we see this lag here after the contractions let up. Our third is variable. And this is really related to cord compression. From contraction, or maybe the baby grabbing the cord. And essentially what we have here is, in the very early stages, when you have the umbilical cord, you have a thin-walled vein and two thick-walled arteries. As that vein gets compressed, you're basically decreasing your preload back to the baby's heart. That's going to cause a sense of hypovolemia, and you're going to get an increase, reflex tachycardia. Once the arteries get squeezed, then you're having an increase in your systemic vascular resistance, and then you're going to get a vagal decrease. Again, this is sort of the same response to try to decrease the heart rate to decrease the blood pressure, and that's going to happen very abruptly. And that's usually, again, reversed as the force is let go. You're going to get, again, a reversal of that process. And as you get to the end here and the vein opens up again, you're going to get sort of a bolus of preload, which is going to give you a reflex tachycardia before you return to your baseline. A variable in general, in order to be classified as such, needs to drop at least 15 beats below, and it should last at least for 15 seconds. However, it should not be greater than 2 minutes. So these usually last less than 2 minutes. One last deceleration is a prolonged. And this is very simply any deceleration that lasts greater than 2 minutes, but less than 10. anything that's greater than 10 minutes is going to equal a change in baseline, and really should be described as such. So again, our main components here for fetal heart rate tracing, when you describe these, we're going to be looking at what is our baseline. How would you describe our variability? Are there any accels? And if there are any decels, and describe them. If you can remember these 4 components when you're describing the fetal heart rate tracings, I think you'll be in good shape over the course of the clerkship.